Thank you to everyone in attendance. I'd like to have the privilege and honor of introducing today's guest speaker, Dr. Leigh Simpson. Many of you may be aware of Dr. Simpson, but I know we have very much a multidisciplinary audience. But certainly Leigh is among, and has been for decades, among the leading thought leaders in the field of reproductive genetics. He's presently a professor at Florida International University, but has been chairman at Tennessee and also Baylor. He has been the president of most all of our major national organizations, including the American College of Medical Genetics, the International Society of Prenatal Diagnosis, Preimplantation Diagnosis International Society, etc. Was elected to the Institute of Medicine and continues to be an active member, and his CV is certainly amazing, with 15 major book chapters and more than 800 papers. But in addition to that, and I certainly could take almost this whole hour in just summarizing what Leigh has done, but I think, as I said, the important thing is he really has been in this field as long as any of us. He initially did a residency and fellowship right down the street at New York Hospital Cornell, in which he took, at the time, what was the cutting edge technology in genetics, which was additional training in cytogenetics, just to speak of how things have changed. He has some seminal work that was done in the 70s, not only in cytogenetics, but the relationship of cytogenetics to sex differentiation and a number of other conditions. If you follow Leigh's interest and activities, it reads like total advancements in our field. After doing the work in cytogenetics, etc., he moved on to being an integral part of the early and pilot evaluation of the safety and accuracy of first trimester prenatal diagnosis by CVS. That was in the 80s. And then realizing the need for non-invasive prenatal diagnosis, spent a large amount of time and great effort working on the attempt to retrieve fetal cells from the maternal circulation, leading to what now has morphed into non-invasive prenatal testing. Leigh's most recent activities is what he will talk about today, and that is the ability to do pre-implantation genetic diagnosis. This really has changed a lot of how we approach families and how we approach individuals who have a genetic risk. So Leigh, thank you so much for joining us and really talking to us about pan-ethnic genetic screening and pre-implantation biopsy, and at least asking the question of, is it time to integrate, and how should we integrate this into our clinical care? So thank you very much.
Thank you, Ron, for that very gracious introduction. You should have mentioned that in most of those areas, we were collaborators on large numbers of studies, and that's actually why Dr. Wapner knows the cycle that I've been through for such a long period of time. So we're going to talk today about pan-ethnic genetic screening, what we would call pre-implantation genetic testing. You will see on the screen Dr. Svetlana Rechitsky, who is my co-speaker, and also the director of the laboratory in which we have worked for a very long period of time, reproductive genetics innovations. So let's go back and start with pre-implantation genetic testing. Why was it initiated, and what changes have been made? It was started in by the late Yuri Valinsky with whom Dr. Rechitsky worked since 1989. This was focused upon the disorders of childhood onset, and the real reason it started was to avoid clinical termination of pregnancies. But this allowed us to test a disorder and make a diagnosis based upon a mutation at a single locus. At the time, it was polar body. It then moved to cleavage stage embryo at about 3 days, and eventually to the blastocyst. This was very simplistic. Most loci were interrogated for only a single nucleotide change. And as we mentioned before, only a single locus at a single time was possible. This is where we are now. So I mentioned Dr. Rechitsky's name, and she's on the screen. She has been the CEO for quite a while. She has supervised and led to over 30,000 PGD cases, performed for 705 different conditions. Those are monogenic conditions. So about a third of the corporate work has been for Mendelian disorders. If you move down to the bottom, you can see that the remaining 2/3 were predominantly for aneuploidy, PGT-Aneuploidy testing. About 4,000 had both PGT-A as well as PGT-M, M being monogenic. But look at the spectrum, because this is entirely different than, say, in the 90s until perhaps the middle of the first decade in the 21st century. So 585 de novo mutations. Remember, that means that there's no one else in the family. This is the first family member affected. And historically in genetics, you needed to have affected and unaffected individuals in order to make a diagnosis in many circumstances. 874 disorders that were of cancer predisposition, 960 of neurodegenerative disorders such as Huntington's, 109 for cardiac conditions, and 500 or more for HLA testing, some with and some without PGT-M at the same time. Now, I'd like to focus today on the cancer predisposition because it illustrates very well the point that every organ system is amenable to preimplantation genetic testing, and it's time for those in these specialties to look out and see how this wonderful technology can be applied in 2022. So here is a list of cancer disorders, cancer susceptibility disorders that Lana has tested over the years, 874 of the 30,000 cycles. Those in white are predominantly of childhood onset, and they've been around for a very long time and typically occur and come to our attention after a child in that family has been affected. But more recently, the attention has moved to adult onset conditions, and these are shown in red, and we will get back to those in considerable detail. And given that these are adult onset cancers, usually cancer susceptibility, what has changed and has brought the in vitro fertilization teams into this field is that the couples are selecting PGT with embryo testing requiring IVF rather than some traditional methods that Ron and I dealt with and helped develop in the 1980s. So there are several reasons why PGT monogenic cycles for adult onset disorders are increasing, and I'd like to go over these. Number one, we now use pan-ethnic expanded carrier screening that identifies many, many more couples at risk. Surprisingly, at the same time that we screen for childhood onset, we are increasingly finding that the heterozygous adults are identified as at risk for cancer susceptibility, almost always different from that of a childhood. So a couple that enters for screening to verify that whether their child may be at increased risk, learns that they themselves are at increased risk. The public and the clinicians are increasingly realizing that gene panels are useful to detect individuals at risk for susceptibility. And finally, as I've just mentioned, once an at-risk couple is realized, perhaps because their parent is affected, then they elect embryo selection, including in vitro fertilization, rather than amniocentesis or CVS. So these are areas that we're going to get back to. Now, returning to where we were initially for in carrier screening, the initial area was ethnicity-based. There are some people around who realized that this included in the 1970s African Americans at risk for sickle cell anemia, the Ashkenazi population at risk for Tay-Sachs, and the Mediterranean populations at risk for beta thalassemia. We had to use protein-based tests. That's all we had. Of course, DNA and sequencing was a pipe dream at that particular period of time. And we had to have disorders in which we could distinguish the heterozygous from the homozygous individuals. There were problems with this. Ron and I recognize this, and many people in OBGYN and reproductive genetics did. The American College of OBGYN at the time realized that only 20% of the population that could have benefited from ethnicity-based screening actually had ethnicity-based screening. Secondly, I don't need to tell you, it's obvious from the slide that very few of the 21,000 protein coding genes could be screened. Third, many people thought they knew their ethnicities, but they did not know their ethnicities. So this was often incorrect. And finally, different ethnicities had different mutations, making it very difficult to come up with a screening technology. Now, we were fooled in the 1990s when DNA came along and sequencing could be done initially on a limited basis. And we were fooled by looking at, for example, the Ashkenazi population. You can see here a list of some 9 different disorders. Their carrier frequency was attractive for screening. The detection rate for heterozygosity was attractive. And the reason it was attractive and possible is that there were only 2 or 3 mutant alleles that accounted for the entire detection rate. And that is something based upon the history of the Ashkenazi Jewish population and the bottlenecks that existed. So this was easy, so to speak, and we could test for 2 or 3 different disorders and have excellent results in screening. The American College of Medical Genetics decided that we could expand this by developing a mutation panel that shows based upon different mutation frequencies, and we added that up to see if we could have a manageable detection rate. So to the left, let's look at the Caucasian European populations as traditionally defined. You can see that the first mutation, the mutations are along the x-axis, cumulative detection is along the y-axis. You have delta F508, we're all familiar with that. Delta F508 in the Caucasian European population consisted of about 70% delta F508, but not so in the Ashkenazi population. You can see at that same mutation level at the x-axis, delta F501, only about 30% were explanatory. And in the second mutation, W1282X, that accounted for the largest numbers. And each of the other mutations were, in general, only added a little bit, reaching in this very initial report, 97 and 89%. Now, if we look at the final panels that were utilized and open to the public, so to speak, we had pretty good results with the Ashkenazi population and the European Caucasian population. 94 and 88% heterozygosity, consistent with the not too far away from the heterozygote frequency. However, what happens with other ethnic groups? Really not very good results. African American, only 65% of the heterozygotes detected. Asian Americans, less than 50%. So this simply was not a desirable and acceptable population, resulted in a great deal of confusion. As a result of that, along came sequencing, first developed by Counsyl, which is now under the aegis of Myriad, and they developed a much more complex and laborious screening technique. It involved 176 diseases with an opt-on for other possibilities. They screened all exons and added copy number variants, and at the end of the day, they could identify 1 in 300 affected pregnancies, which are at risk for 1 in 22 couples. This is pan-ethnic now. It's not for any given ethnic group, but for the entire populations, including South Asians, for example, as well as traditional populations that we deal with in North America. These vendors still offer expanded carrier screening, and this shows the risk, the numbers of disorders that are available for each of these conditions. So Sema4 and LabCorp, as an example, basically seek to have the highest number, over 500. Myriad still has the 176, and Quest a similar number, and Natero is somewhere in the middle. All of these work. We utilize these, and they are useful for identifying couples at increased risk for disorders that many of us have frankly not heard of very frequently, but still are useful. The American College of Medical Genetics decided that it would be better to come up with a method that could be useful and applicable to everyone and to all vendors. And Anthony Gregg and several other reproductive geneticists and the hierarchy at the American College of Medical Genetics pursued this. And the strategy is shown on this slide. They begin with 415 autosomal recessive genes that are recorded in a genome. They look for a carrier frequency of 1 in 200 or greater. To avoid getting confused, greater than 1 in 200, remember, is a denominator less than that, 1 in 150, 1 in 100. And this could further be stratified according to the 6 ancestral groups that we've looked at. Requirement for screening was a moderately severe phenotype. So what was the strategy and what was the found? So first of all, you could look at genes whose frequency were in tiers 2, 3, and 4. We're dealing with tier 3, in which the carrier screening should be 1 in 200 or greater, meaning 1 in 100 or less. If we simply restricted ourselves to tier 2, we would have uneven distribution in certain ethnic groups, and that was not desirable. If we went to tier 4, that was too infrequent, although this tier 4 mutations and screening can be useful in the consanguineous populations. So what was found and what was recommended in a paper in Genetics and Medicine in 2021? The tier 3 genes that appeared suitable to recommending screening were 87 recessive genes meeting the base criteria of 1 in 200, and an additional number that were special because they were restricted to a given ethnic group. There were in addition 16 X-linked genes, and this provides us with a sum total of 113 genes. So this is the American College of Medical Genetics screening possibility. Now, what has happened to Reproductive Genetic Institution and the innovation and the PGT for monogenic disorders? Well, this is a slide that shows where patients came from. So in 2015, the red indicates those individuals that were referred after a previous child with a autosomal recessive or an X-linked recessive condition. The blue represents those that were referred not with the family history, but only after they had carrier screening. And to the right, you see the results in 2021. So the number that came for after carrier screening has gone from 26% of the total up to 41% of the total. And there's no doubt that this population and this tendency will continue to go forward. Now, on the other hand, it's pretty clear, and the American College of Medical Genetics noted this, that not all genes causing a condition may be known or examined. You have locus heterogeneity, for example. Not all causative variants could be identified, included in the test, or detectable by analysis. Some, for example, were telomeric. And the variants of unknown significance, I don't need to tell this group, may be misclassified with respect to their pathogenicity. So in addition to that, we have found, let me go back one slide here. I mentioned before that when you screen adults to detect childhood onset disorders, you surprise yourself because you detect other individuals at risk, that is the parents. So number two, note that the heterozygote results prove to be at risk for disorders different from those of the at-risk fetus. And the most obvious example is that carrier screening for autosomal recessive ataxia telangiectasia or Fanconius, both conditions that have chromosomal breakage, also identify heterozygous individuals, obviously, and these people are at risk for breast cancer. So the couple who is being screened has a surprise, and one is detecting more disorders and those that they did not anticipate. I'd like to generalize that and say, as we know more and more about the etiology of disorders that we thought we knew well, we're finding out that they are due to defects in DNA repair and the likes. So in premature ovarian failure, disorder that I've had interest in for a very long time, you can read off the screen 4 different conditions, and they are caused not by abnormalities in the X chromosome, for example, but by autosomal genes. So STAG3, for example, produces cohesin, which is necessary to maintain functional pairing of, for example, sister chromatids. MSH4 forms a heterodimer that facilitates synapsis. Synaptodema complex confirms the homologous chromosome pairing before crossing over is permitted, and MCMA, 89, repairs double-stranded breaks. And in fact, if you look ahead, this is from a chapter I have that will be published in the latest Emery and Ramoyne, looking at autosomal genes that cause ovarian failure. And each of these conditions, it's about a dozen here, are related to DNA repair. And so I predict that as we look at many, many other disorders that are predominantly involve a single organ system, we're going to find that, and this will continue to increase the number of couples that will choose PGT. Now, the other aspect that's occurring, in particular with respect to cancer, is the increased recognition by the general public of cancer susceptibility. So there's increased realization in general that cancer in adults, not just in children, is genetic. So the public population generally, I think, is accepted that many cancers in childhood or genetic in basis, such as the leukemias, but they didn't have the same thoughts about adults. There's an increasing realization by clinicians that the same gene can cause cancer in multiple organs. That's confusing. And likewise, cancers of adult onset may be autosomal dominant, and as we mentioned before, place relatives of probands at increase for germline mutations. So translating those into what we need to know as geneticists or as providers with genetic proclivities, germline susceptibility is now followed by somatic hits. We've known that for 40 to 50 years. That's Knudson's two-hit hypothesis. Remember that the germline susceptibility is the one that we would be screening for because it's there with or without the manifestation of cancer. Many disorders are autosomal dominant. That's different than what we usually see in most screening for childhood onset conditions, and they result from a de novo mutation. And we'll talk about that in just a little bit. The pleiotropy of cancer-causing genes affects multiple organ systems, not just one. Different genes can cause the same clinical cancer in a single organ system, locus heterogeneity. So number 3 and 4 are more or less the converse. Number 5, molecular heterogeneity exists in a given gene with respect to causation. That's very, very important in terms of detection and diagnostic criteria. And at the same time, because of that, many mutations can be unique to a single family. So just to explore the first of those, several of those concepts, this is the gray represents the general population percentage. The blue represents the heritability. If we take, for example, the breast cancer, 7% in the general population develop breast cancer, 87% if you have BRCA1 and CA2 by age 70. Ovarian, 0.7 versus 63%. But look at the surprise over here. It's not just women, it's prostate cancer as it relates to men, of course, pancreatic cancer, both sexes here. And once again, those with BRCA1 or CA2 have several-fold increased incidence by the age of 70 compared to the general population. So I would generalize by saying a cancer susceptibility gene is prone and almost characteristic of pleiotropy, many different organs, and has a much greater incidence and prevalence in the population in terms of cancer itself than the general population. Now, even more surprising, at least to me when it started, was this. So let's look at the left-hand side of the screen, and you can see individuals with breast cancer. So many vendors now offer a screening for multiple genes to see if you have a cancer susceptibility gene for any of these. And so for breast cancer, there are 11 genes that are focused here. BRCA1 and CA2 are the most prevalent, we're all aware, but look at the others that exist there. I won't name them all, but they add up to multiple genes that are producing an increased risk of cancer, all of which are germline mutations. But let's take any of those genes. TP53 as a simple example, tumor protein 53. So let's put that in the middle and ask what other organ system cancers can it cause? And you can read them off: breast, ovary, gastric, colorectal, pancreatic, melanoma, prostate, uterine. So a single cancer-causing gene can manifest in different organ systems, many different organ systems. And just to emphasize on a single slide, what happens if these autosomal dominant disorders are detected in a parent, say age 50? Well, that parent is highly likely to have some children still in the reproductive age. And what would they choose if they knew they were at 50% risk? Well, they could choose conventional amniocentesis or CVS, but this could lead in half of the prenatal diagnosis to the conundrum of undergoing clinical pregnancy termination. Better would be in vitro fertilization, even though it's expensive, not essential to become pregnant, of course, but it allows embryo selection and choosing unaffected embryos for transfer in these situations. And this is the case chosen by about 60% of the couples. So it's much more commonly chosen than amniocentesis or CVS after the natural selection. So here are is the increase in pre-implantation genetic testing for cancer only predisposition. So the first that reproductive genetic innovations did was in 1999. Those are fairly famous cases in the media and with a lot of attention, but not a huge number were chosen really for the next 10 or 15 years. But in the last 5 years, the numbers have jumped up increasingly. 2016, for example, just a little over 60, and now over twice that, nearly three times that number in 2021. So cancer predisposition requiring in vitro fertilization and embryo selection is here. Ron said, are we ready? Well, we have to be, because the patients are wanting, and it's clearly that this is moving forward at a very rapid rate, not just for a single organ system, but really for all. Now, what are the pitfalls in management if we're going to embark upon adult onset PGT for these conditions? Molecular heterogeneity must be taken into account. De novo mutations are frequent. Allele dropout must be excluded by linkage analysis. So let me simply show you how we approach that at reproductive genetic innovations here. So I mentioned the molecular heterogeneity. Let's take BRCA1. BRCA1, the most common mutation is 187 deletion of AG, and that was detected that was present in 87 families that presented for this condition. However, in more than that, in 91 families, there was a unique mutation that was present only in that family. So the unique mutations were much more common than the most prevalent. And clearly, you could not identify 2 to 3 single mutations. And as we did for Tay-Sachs disease, for example, we would not be able to diagnose many cases. For BRCA2, 6172 deletion of a T, in this case, about the same phenomena occurred. 46 of these were identified with the most prevalent mutation, but 60 had the unique mutations. Now, this is not just cancer. This is neurodegenerative disorders. You can see the top 3, Huntington's, spinocerebellar ataxia, and Charcot-Marie-Tooth were the most common, but they certainly were not the only ones, and you can see large numbers. When we think of neurodegenerative, we think of Huntington's, and we think of couples that want to be tested without knowing. They want to have children that are unaffected, but they don't want to know whether they have Huntington's themselves. So look at the numbers over the years, 78 of a total of 95. Increasingly, Dr. Rechitsky is utilizing the ability to determine whether a couple is at risk or whether they have an affected embryo by what's called indirect non-disclosure. The top of the screen is blank, but I will try to take you through this. So here's a family in which a father had cancer, transmitted the gene to his daughter, and she was a 31-year-old patient diagnosed with breast cancer. She had an oophorectomy and a hysterectomy, and she obviously still was interested in her own biological children, or to have one. She had a sister who volunteered to be the ovum donor, and we could look at the mutations that were present in her 2 chromosomes for the gene in question. The red ones are those associated with the chromosome that has the cancer-susceptible gene. The blue ones are the ones that do not. So the blue one is inherited from the mother, and this one, the red ones, had to be from the now deceased father. And when we looked at that, you could tell that there were half of the mutations in the embryos that this woman went for in vitro fertilization. This one, number 4, number 6, number 8, 9, and 10 could not be transferred, but the others could be transferred. We always do a preimplantation genetic testing for aneuploidy, and that's shown down here. So embryo number 1 was good. Embryo number 11 was not good. It had monosomy for this particular condition. And the same thing for cardiac conditions as well. All of these are autosomal dominant disorders in general. In fact, they all are autosomal dominant disorder. So everything I've said about cancer, everything I've said about the neurodegenerative disorders hold. And when you look at these 3 late onset disorders alone, you can see the numbers of cycles that have presented themselves. 874 for cancer predisposition, 109 for cardiac, 960 for neurological conditions, 485 for HLA, or 2,400 conditions that have been subjected to this because they're adult onset. Now, there are many, many more, and I'm not going to go through each of these organ systems, but these represent the books that authors at Reproductive Genetic Innovation have produced over the years. This one is the latest, 2020, the 3rd edition of Practical Preimplantation Genetic Testing. And trust me, it really can be practical. And if you're interested in other organ systems, pulmonary, for example, bone marrows and things like that, please look at that. And if you have questions, you can discuss this with Dr. Rechitsky, whose email is at the last slide that we will show here and is available for questions and answers. Now, what are the pitfalls in the management of this? And this is the closing section we're dealing with here. We've already talked about the molecular heterogeneity that must be taken into account for adult onset cancers and for any condition, especially adult onset because it's more prevalent. De novo mutations I have mentioned, they are very frequent and very often we have no other affected family members. Allele dropout is something that has existed and must always be excluded, and that's because whole genome amplification for the mutant allele is only about 95% efficacious. That means you'd have a 5% error rate if you did not do something else to exclude allele dropout being present. And finally, PGT-A in combination with PGT-M is always needed to maximize the pregnancy rate. So I'd like to spend the last few slides going over each of these in yellow to see how this is approached. So if you have a male who manifests an autosomal dominant disorder or even of other conditions, you have an easy time. This individual must have 2 populations of sperm. In this case, keeping the same color scheme that we had before. The blue has a normal allele in the middle, and then on either side, there are biomarkers, so to speak, if you want to call that, or DNA variants. And if that's associated with a given sperm, that's a sperm that's worth identifying and using to produce an embryo. On the other hand, the converse, of course, would not apply for an embryo that has the mutant allele, not shown, not easy to see here, plus the biomarkers on either side. So in the end, you would have the potential for 3 different embryos. 2 of these would be transferable, and the other one would not in this particular case. And the same thing down here, if you want to look at this, this would be a tuberous sclerosis. You can see not a transferable embryo, not a transferable embryo, not transferable because it is missing a chromosome. And so there are embryos number 4 and 5 that can be transferred. So the de novo mutations can be solved. You should not discourage patients who are in that situation. Now, what about the allele dropout? So let's go down and look at a patient who has BRCA1 toward the bottom. Here's the mutation right here in red. And you can see consistent with that on either side are the biomarkers, in this case, variants that are associated with the mutation. And you could go back up here and you can see embryo 6, 8, 9, and 10 have the same thing, embryo 1. But what about number 3? There is no signal from the mutant allele, so we don't know whether it's normal or whether it is the mutation here. We do know, however, that all of to the left and the right here, we have several examples in which the mutant chromosome biomarker is shown. You can see 104 and you can see 167. So these are valuable, and you can deduce that the allele dropout, in fact, was for the mutant allele. Now, found few slides. I mentioned that PGT-Aneuploidy should always accompany PG for monogenic disorders. These are our results. The pregnancy rate is shown in red just for monogenic testing, and in green if you add aneuploidy testing at the same time. The pregnancy rate goes up, the miscarriage rate goes down in this situation. Is PGT-A accurate? Even in the New York Times today, I still see issues concerning this. Here is the original report of using array CGH or qPCR in the early eras. These are RCTs. The results are not in doubt, just like 69 versus 46, 80 versus 63. And of course, the meta-analysis of all of these shows that PGT-Aneuploidy work. I mentioned one other thing because this comes from a Columbia faculty member. This is a study that Eric Foreman did in 2013. It was an RCT comparing what happens if you transferred a single PGT-A verified embryo with an untested but morphologically normal embryo. So first of all, in this box to the left, they have really the same pregnancy rate, 61 versus 65. The next pregnancy rate shows the singleton and the mutations. And here is the singleton. If you transfer only a PGT-A embryo, there are all singletons and no twins. On the other hand, if you don't exclude, if you don't verify that you're testing PGT-A and you test and you transfer 2 embryos rather than 1, half of the pregnancies were twins in that particular group. Now, there is a new toy on the network, so to speak, that is worth mentioning just to tell you that it's not as complicated as you may think it is. So it used to be in amniocentesis and CVS that we could literally count every cell. But once we're testing an embryo, we can't do that. Instead, what we do is biopsy and base the number, the karyotype, so to speak, on the number, the amount of DNA that's tested. So if we have, and we compare our sample to a reference sequence. So if we have a normal 46XX embryo, we will see that there is equivalence of the reference sequence with the biopsy. Perfect. Here's one, and that's what's that doesn't occur. This portion here for all of these chromosomes up to number 15 are completely normal. Same amount of DNA in the reference library as well as in the sample, but you can see now only half. This is 1X, 2X, 3X, so to speak, and this represents monosomy for this chromosome 16 and over here. Over here, we have the same reasoning ability for trisomy, and everything is equal in the reference sequence versus a sample, except for chromosome number 2. Now, you can always have also have a situation in which you do not have complete trisomy or monosomy, and it's shown here. So if you had, you see less DNA in chromosome number 2, more DNA in chromosome number 6, but they never reach the level that we would expect for trisomy or monosomy. So therefore, this is mosaic. And we have the same thing over here in several other examples. It seems very, very simplistic, but it's very easy to replicate. Now, what happens and how did this occur? Well, one possibility is that the mosaicism exists on the basis of where the biopsy was taken. So, for example, if we had a biopsy at 12 o'clock here, this would be euploid. And we could also have in that same sample a mosaic embryo because the biopsy at 3 o'clock had 1 red and 2 blue, or it could have been something else there. Intercell mass could also be abnormal with the trophectoderm completely normal in this particular situation, or the converse. The trophectoderm could be aneuploid, but the intercell mass could be normal. So this produces a whole series of mosaic options that exist. This is what happens. The mosaic embryo that consists of whole chromosomes is generally still called whole chromosome mosaicism. In the reproductive genetic innovation sample of about 15,000 embryos, there were 8% that were mosaic for whole chromosomes, 14% for what we call partial or segmental, and these are usually chromosomes, embryos in which we have interrupted the cell cycle, and therefore it's simply not complete, and we recognize that because it frequently involves the larger chromosome. Now, what happens if you transfer these? So originally there was panic, say in 2016, and then people said, well, we're killing a lot of embryo. The technology is wrong. We now know a simple answer. So this is the frequency of implantation if by next generation sequencing, we transfer a euploid embryo as we've defined, that is no more than 20% non-modal cells, non-modal DNA. If you have just a little bit of mosaicism, less than 50% total, the results are almost as good as if it was a known euploid. On the other hand, if you have, say, between 50 and 75% of the DNA content is aneuploid, it's much lower. There's nothing that says you can't transfer any of these embryos from 21 to 79. It's just that the patient needs to be informed that you're going to have a lower implantation rate and a higher miscarriage rate. Now, what happens? Here's a series of 1,000 mosaic embryo that's put together in a collaborative group by Emmanuel Viotti from California. And the bottom line take-home message, if you take all of these, not taking into account the exact percent of mosaicism, 80% are ongoing after 20 weeks. So it works. 20% are going to have late onset in birth. And these are going to, these 79%, I'm sorry, are going to yield a positive result. Stillbirth in only 1%. 20% will be abortion. So divide these two here. 80% are going to go ongoing. 20% are going to be a miscarriage. That's about what you would expect based upon the age group. So what's the take-home message here? Expanded carrier screening has increased the detection of childhood onset genetic disorders. Adults that are screened for offspring at risk for most carrier screening autosomal recessive disorders unexpectedly find that they are heterozygous and susceptible for autosomal dominant cancer. That's a big take-home message. Number 4, gene panels are increasingly being used in both directions. If you take a given gene, it can show increased risk for multiple organ system cancers and the converse. The spectrum of autosomal of adult onset disorders includes not just cancer that we've emphasized, but cardiac, neurodegenerative, and multiple organ systems. And finally, given an affected parent or other family members at risk for an adult onset heritable disorders, the majority are preferring PGT-M, wanting to undergo in vitro fertilization because it allows for selection of an embryo. So I'd like to thank you for paying attention and being with me. And the emails for myself and Dr. Rechitsky are shown here. We are both available for questions if you have some.
Great. Thank you, Jolie. Thank you so much. The world has changed and is continuing to change. Do we have any questions? If so, if people could just put that into the chat. That would be great. Okay. So Jolie, we're going to be doing healthy women cancer screening. It doesn't make sense to wait till you identify someone affected in the family, but all of these individuals are going to find out that they have a predisposition gene and then their offspring. So is your vision that when we will be doing healthy women's cancer screening, we'll be screening both for the mother and also, or the father, and also the offspring so they can get PGT-M?
Well, I guess I would answer it. Number one, if anyone has cancer, all of the largest number of their offspring are at risk. 50% are going to be at increased risk. So at that stage, we're not screening, we're testing. So that's a different condition right there. I would suggest that you screen for a limited number of conditions, say 8 or 10, and anyone can give you that number. You are going to increase someone with the germline mutation. The good news is that that is not cancer itself. You've identified someone at increased risk for cancer, and it's worth screening for based upon that. The trick is where are you going to stop screening? I showed you the slide in which breast cancer, if you're screening for that, there's 12 different disorders, each of which puts you at increased risk for many other conditions. So this is a genetic counseling issue. Fortunately, got a great genetic counseling program at Columbia, so you can put together what you're going to proceed there. We have a question, I think, that goes to everybody, but I'm going to bounce it to Dr. Rechitsky. It's the first on the screen, and that's, is the NGS data and analysis available to the public? Lana, want to take that one?
Sure. Can you hear me?
Yes.
Okay. So yes, it's available to the public, and almost in every issue of Fertility and Sterility magazine, you can find papers about NGS, next generation sequencing, for copy number, especially since we learned about mosaicism. Because since 2016, mosaicism became a very big issue and stirred a lot of debates, and all of them were published, including the latest data demonstrated by Dr. Simpson. It was published in 2021 by Viotti and other authors, where they described the outcome of mosaic embryo transfer, but also the input of PGT-A or preimplantation genetic testing for aneuploidy is and its impact on pregnancy and take-home baby rate is also published in Fertility and Sterility. And as Dr. Simpson mentioned, we also published it in our 3 editions of Atlas and 3 editions of Practical PGT.
For those of you laboratory proclivities interested in expanding this to other organ systems or to contribute to what's already in progress, the atlases are providing extensive detail, with by Lana, because she's the one that developed these techniques or so. So it's really impressive what is available already and does not need to be, the wheel does not need to be rediscovered. That's the reason her email is here. The laboratory people may be well interested in that area. Ron, you would be interested. I read the New York Times today and noticed that there was continuing discussion about mosaicism. And I love the quote from Norbert Gleischer, who in general has been skeptical in this area. And he said, in terms of transferring embryos, and he basically said, you know, what would you prefer? No embryo and no baby, or transfer and a miscarriage? So I thought that was well stated in terms of what the public needs to know in terms of moving forward. So not all mosaic embryos are going to be ideal, but if that's the only embryo you had, you should transfer it.
Yeah, and actually, as you pointed out, when you first started noticing the mosaic embryos, nobody would transfer one. And we went through a couple years where throwing away a lot of embryos with low-level mosaicism because someone wouldn't put them back in. And then that's exactly what happened. People which that was the only embryo they had, it was their last chance, put them back in, and lo and behold, everything turned out okay. So, you know, as all these new technologies develop, we still have a lot to learn. And it's taken us, with all of this in mosaicism, I would say more than 5 years to figure out the best way to implement them clinically.
Yeah, I think the take-home message is it's better to have a euploid embryo, meaning that that there's never zero aneuploid cells in a euploid embryo because of cell cycle and the likes of that. But if it's less than 20%, we define that as euploid. And then the closer to that 20% you get, the better the outcome in terms of implantation and failure of miscarriage. But still, if you have no other option, it's not worth throwing away any mosaic embryo. Probably for various reasons, if it's greater than 80% aneuploid, that's a real aneuploid. And I think for litigious reasons, if nothing else, it's unlikely to transfer. We have another slide state here. Are there any data which says which to avoid? If the question means which chromosome, we went through a stage in which we thought we would identify those at risk for uniparental disomy or for a given syndrome. And so some of the early position papers had that, but we have cut that out now, realizing that probably we simply don't know which chromosomes are eventually going to show UPD, maybe more than what we have now. And of course, syndromes can occur in any chromosome. So it's really naive to think we could exclude that. So the answer is don't worry about the chromosome involved if that's the mosaic that you deal with. I might add that if you look at the numbers, only a limited number of cycles will present the clinician with the idea that you must transfer a mosaic embryo. It's usually about 1 in 10 or less than that. So it's not a lot. Usually it's not necessary.
Jolie, we've reached the end of time. The end of the time for this meeting anyway, although some days I feel like it's the end of time. Thank you so much for helping us learn about this. Really appreciate your spending the time with us. It's a shame with virtual we can't clap and reward you, but thank you. It was great.
All right, thank you. Okay.
Thank you.